All right. Happy Thursday afternoon, everyone. I'm pretty sure it's afternoon where most everybody is that's joining us. We want to welcome you to our Reducing Medicaid Churn, Keeping People Covered After COVID-19 and Beyond. It will end, I'm sure, at some point. We want to thank you for joining us today. We're going to do introductions in just a minute, so you don't get to find out who I am until then, except you can see that I am Erin Henderlight, BDT's Director of Policy. Before we get started, the very first thing we want to do is thank the Robert Wood Johnson Foundation for providing support for this project. I also want to thank BDT for being an organization that sees the need for this and acts on it. And I definitely want to thank Jamila McLean, who is the visionary behind this and the one who has put all the energy and effort into putting together this toolkit, and who is going to be the one who is presenting mostly to you. I'm really just here for the moderation. But I will turn it over to her in just a minute. So it seems like most everybody has joined, so let's go ahead and get started. Just a little bit of housekeeping before we start. The webinar presentation will be recorded, and the recording will be shared with the registrants and posted to BDT's website. Oh, it seems like I'm echoing. So hold on just a minute. I'm going to pause and see if I can take care of that.
I think you're fine, Erin. I think that user joined twice, which is why they're getting an echo.
Great. I am also monitoring the chat, so double duty here. Thank you, Brian. So back to the housekeeping. We will make sure that the recording is sent out to all the folks who registered, as well as posted on the BDT website. Everyone's lines are muted, and as some of you have already found, please join us in asking a question or communicating Q&A via the chat function. I will try to, as Jamila is talking, monitor that. We will hold most of the questions until the end, but certainly I will reserve the right to jump in and make sure that she clarifies something, we answer something that's a little bit more pressing. So just in terms of how this is going to go, she and I are going to introduce ourselves. I'm going to give you a little bit of an overview of BDT. I suspect most of you know who we are, but just in case you don't, I'll spend just a couple of minutes on that. And then I will turn it over to Jamila, who will talk about Medicaid churn, the impact of COVID-19 on churn, and then really walk folks through the toolkit. So as I alluded to / also told you, I am Erin Henderlight. I am BDT's Director of Policy, and our main presenter today is Jamila McLean, who can introduce herself just a little bit more when we get started. So BDT in general as an organization, I don't need to read this to you, but we're about a 15-year-old nonprofit headquartered in Philly, but certainly working across the country. And this is our mission statement, but also I think it's important to say that what we really envision is a world that connects people to essential benefits while treating them with dignity and respect. Just a little bit more, I think, helpful here, which are our strategies. We are very much centered on data analytics and technology, so doing data-driven outreach and assistance and tech-enabled assistance. We provide direct service, and I'll show you a map in just a minute of our direct service states. So serving people in ways that are best for them, screening people for multiple programs, providing an individualized outreach and engagement, and really very much, as I mentioned a second ago, true to our vision and mission, treating people with dignity. Policy and practice solutions, which is where I sit and where this project sits. Policy and practice solutions to states to really streamline access, focus on data sharing, outcomes-focused research, but really in a way that helps assist states in addressing the main policy and practice problems that folks have in order to streamline access to benefits. And then partner engagement, right? So working with philanthropy, nonprofit, national organizations, CBOs, MCOs, healthcare plans, academia. I can keep naming things and naming things and naming things, but really a core tenet of BDT is working with partners to try to work together to solve problems that we all have some various piece and part of. So I thought that was a little bit helpful information for you as listeners to understand what we are and what we do as an organization. So where we work, BDT works with a variety of partners. The green states, or this kind of tennis ball colored on the map, are the policy and practice assistance states. And then the dark blue are direct service states. This is reflective of our work in 2020. So as you can see, we've spread out our footprint beyond sort of the Philly and New England area and are in quite a handful of states across the country. And hopefully there are folks here from some of those states. So at this point, I would like to turn it over to the main act, Jamila, who will give you an overview of churn and then walk you through the toolkit.
Thanks, Erin. I hope everyone can hear me okay. So as Erin said, I want to quickly introduce myself. My name is Jamila McLean, and I am the Healthcare Policy Manager at VDT. I'm one of the policy managers here, and as my name implies, I focus on healthcare policy, primarily Medicaid policy, and serving as sort of the subject matter expert, both internally in our work as well as in providing technical assistance to states. And this was one of our main projects that we focused on over the last year or so. So I first want to, echo Erin's thank you to the Robert Wood Johnson Foundation for supporting this work. But I also want to express my sincerest gratitude to all of the national and state experts who contributed to this project by participating in key informant interviews, which really helped inform the development of all of the tools within this toolkit. When we began this work in early 2020, we were blissfully unaware that more than 12 months later, we would be in the midst of a global pandemic, and the Medicaid churn would essentially be temporarily non-existent. And we are truly grateful that we have been able to create a relevant and timely resource that can help states prepare for the end of the public health emergency and the inevitable resumption of Medicaid churn. We began this work with the overarching goal of creating a set of actionable tools and resources that can advance state strategies to improve continuous access to Medicaid coverage. And the tools would be informed by two main information gathering activities: an extensive review of literature and key informant interviews with national and state experts, as I mentioned. The information that we gathered through the lit review and the key informant interviews really illuminated several key points. First, that Medicaid churn, which is the cycling of Medicaid beneficiaries on and off of the Medicaid program, is a persistent problem within the healthcare delivery system that most of you already know has existed both before and after the enactment of the Affordable Care Act. Second, there are several policy and process options states can pursue to help reduce the likelihood of churn and mitigate its impact. And third, there is no one-size-fits-all approach to how a state should address churn within their Medicaid population, and that there are several factors such as politics, data and technology limitations, and resource constraints that greatly impact what is feasible and sustainable for a state. Now, I know many of you are familiar with the phrase Medicaid churn, but I wanted to provide a brief overview and say that churn can be broken into two buckets: procedural churn, which occurs when an individual loses coverage as a result of administrative barriers, such as missing or returned mail; and eligibility churn, which occurs when an individual loses coverage due to changes in circumstance that can temporarily make them ineligible for Medicaid, such as fluctuations in income. So why is Medicaid churn important? And next slide, please. Now, we know from several research studies that churn has a negative impact on the overall healthcare delivery system, resulting in poor health outcomes as a result of delayed care and due to gaps in coverage, also resulting in higher healthcare costs overall because of increased emergency room utilization, again, as a result of lack of access to preventive services and that coverage gap. And also higher administrative costs overall, which are associated with the processing and reprocessing of beneficiaries. And it's also really important to highlight that Medicaid churn also directly impacts the ability to achieve health equity. Research has also shown that 55% of women with Medicaid coverage at delivery experience a coverage gap within the following 6 months. Additionally, people of color and those with less education experience greater income volatility, which puts them at a greater risk for experiencing churn because of those fluctuations in income. Next slide, please. Now, I think everyone knows that the COVID-19 pandemic has had an undeniable impact on the healthcare delivery system, really highlighting mass inequities in access to care, but it has also created opportunities to be responsive and innovative in ensuring that citizens have continuous access to health coverage. As most of you are aware, under the Families First Coronavirus Response Act, states receive a 6.2 percentage point increase in the Medicaid federal match rate, but must adhere to several maintenance of effort requirements, one of which is the continuous coverage requirement. And this requirement prevents states from disenrolling most Medicaid beneficiaries for the duration of the public health emergency, regardless of change in eligibility. But as I mentioned, that requirement is tied directly to the public health emergency declaration, which we know will ultimately come to an end. And as the public health emergency continues on, there is growing concern that millions will be at risk for losing coverage. A recent urban analysis actually predicts that Medicaid enrollment will decline by 15 million once the public health emergency ends, but virtually all of those individuals losing coverage would be eligible for other sources, whether it be through the marketplace or through an employer. But I think that it's important to flag that that report does not take into consideration the millions more that could lose coverage as a result of procedural or administrative barriers. And as we approach the inevitable end of the public health emergency and the continuous coverage requirement, we are hopeful that this toolkit can help states consider policy and process options to mitigate potential coverage loss at the end of the public health emergency and really establish systems that can reduce churn overall beyond this pandemic. As we mentioned, there is no one-size-fits-all approach to policy and process change. So we designed this toolkit to provide step-by-step guidance and templates to facilitate goal setting, collaborative planning, and execution. And you can go to the next one. So each tool within this toolkit is intended to be an independent resource. However, we really do hope that the users will be able to use all of the tools together collaboratively to really understand Medicaid churn and its impact, to evaluate the impact of current policies and practices on Medicaid churn within their state, to plan for and engage in external stakeholder engagement, to gather information about data availability and how data is currently being utilized, and to develop an informed action plan that can move them from information gathering to actual implementation of policies and processes that improve and reduce essentially Medicaid churn. Now, I do want to spend the next couple of minutes really running through each individual tool. And I know many of you have had a chance to review the tools thus far, and they're all available on our website. So the Readiness Assessment is the first step or the first tool in the toolkit, and it's organized into two components. We designed this tool to take users through a series of questions to gauge leadership awareness and motivation for change, and the general availability of resources to do this work. Now, we know it's highly unlikely that any state will be in a perfect state of readiness to address churn. So we want to flag that a low readiness score does not mean a state cannot or should not move forward with this work. Rather, we actually hope that states and the users of this toolkit will utilize the questions within this tool to really foster conversation and brainstorm around the action steps that can be taken to increase readiness, to move this work forward. We also hope that the additional tools or the additional tools or the subsequent tools within this toolkit can be resources in helping to increase leadership awareness and in helping to assess where other resources can be utilized to address churn. Next slide. The second tool within this toolkit is designed to help establish goals for addressing churn. Having goals that are specific, measurable, attainable, relevant, and time-bound, i.e. SMART goals, help provide states with a framework for how to move this work forward. The goals can be used in multiple ways. First, to identify the core internal staff who will need to be involved for this work to be successful, but also to gain buy-in across the agency. So staff that are needed to do this work are willing to dedicate the time and the resources to do this work. It also provides a framework for determining how to assess the effectiveness of any changes that a state wishes to pursue, how they are enacted. And this then leads us to the third resource within this toolkit, building the core Medicaid churn team. Identifying the right staff across the agency and identifying representation from staff that oversee policy development and implementation, data systems, as well as eligibility and enrollment processes. Ensuring that all of those staff that are identified and engaged in this work ensures that the responsibility for success is shared across multiple departments. We designed this tool and we hope that users will use this tool to clearly articulate the expertise that each member brings, how each team member will contribute to achieving the goals that were put forth in the previous tool, and will hold themselves accountable and will establish processes to hold themselves accountable along the way. Now, this goes for all the tools, but I want to say it here. We do intend for this to be a dynamic resource. So it should be revisited as needed and as appropriate as additional personnel needs are identified, and can serve as a point of record when staff changes occur. So folks can easily jump into this work and pick up where others have left off. And in the same vein of shared success, that leads us to our next tool. Engaging external stakeholders. This tool we designed to help the core team identify the right external stakeholders to engage in this work. As we already discussed, churn has ripple effects across the entire healthcare system, and therefore engaging external stakeholders who bring expertise and resources that may not exist within the Medicaid agency can significantly increase the likelihood for success. For example, in our information gathering activities and our key informant interviews, many have suggested that and have mentioned that managed care organizations may have access to more accurate beneficiary contact information, which can result in more successful outreach to members. Additionally, consumer advocates and beneficiaries can shed light on the pain points that they experience in the renewal process, which can in turn inform how policies and processes are implemented. By intentionally engaging external stakeholders at the right time, the core team can mitigate potential unintended consequences that may arise from any proposed policy and process changes. Additionally, it helps to ensure that changes create efficiencies overall, rather than shift the burden from one entity to the next. We designed the tool to encourage users to think really strategically about how and when stakeholders are engaged, and to consider opportunities for engagement that may already exist. We also designed the tool to have users think strategically about how to evaluate stakeholder engagement initiatives to ensure that the relationship is mutually beneficial for all of these stakeholders involved. I'm sorry, I needed to pause for some water. So the next two resources within the toolkit are planning worksheets, both of which have been designed to help states assess the current data, policy, and practice landscape within the state. The first planning worksheet takes users through a series of questions intended to document what types of data are available to measure churn, how the data is currently being used, and how the data are stored, managed, and maintained. And we really tried here to encourage users to consider where the data available can be disaggregated across multiple variables such as race, gender, age, etc., to really better identify populations at greater risk for churn or populations that require a higher level of support. Additionally, we really encourage users to consider opportunities to work with and leverage external stakeholders that may have been identified in the previous tool with expertise in specific data sources or in data analysis to help support efforts to understand how the data can be utilized to understand both the impacts of churn on Medicaid beneficiaries as well as on the agency itself, and thinking through how the data can measure the impact of churn on cost outcomes, on administrative outcomes, as well as on healthcare outcomes. Now, the second worksheet, like I mentioned, asks users to document the policies and the processes that are already in place to address churn. As we mentioned briefly at the top, we know that it's also highly likely that policies and processes already exist within a state, We don't think states are coming to this starting completely from scratch. And we want to be mindful of that. So we designed this tool to help users really think through and build on and strengthen what is already working well. And in addition, to consider new and innovative opportunities. We really encourage users in this tool to engage and leverage external stakeholders, again, that they have previously identified, to understand how existing policies and processes may affect each stakeholder differently. By getting a complete picture of all of the policies and processes that exist or that already exist to address churn, it can help inform more, it can help guide states to more informed decisions about what policy changes or what process changes can be made to improve upon and build upon what already exists. Next slide, please. And finally, this brings us to the last resource within the toolkit, which is the prioritization table and the action planning tool. As I said at the top of the webinar, and throughout, there is no one-size-fits-all solution to policy and process change. As I'm sure many of you are aware, policy options such as continuous eligibility, such as aligning renewals using SNAP data, such as improving the ex parte process. There are many, many possibilities that exist and that a state can take up when it comes to improving and reducing Medicaid churn. So we designed this tool to take states through a series of questions that can help them really prioritize which solutions to move forward with. We ask states to assess each potential solution across 4 key prioritization factors. First, risk. What are the potential unintended outcomes of moving forward with a specific solution? Who will benefit? Who will be harmed? Secondly, value. Who will benefit from this change? How many people will benefit from this change? Is this something that is going to be beneficial for Medicaid beneficiaries, but have a negative impact on eligibility workers? Really thinking through where the value in that potential solution is. Third, cost. What are the resources needed to make this change? Both in terms of actual dollars and cents, but also thinking about the staff time that would be needed, that would need to be dedicated to implementing any policy or process change. And finally, effort. How much work would this take? How long would this take? As we think about the upcoming public health emergency ending, thinking about whether solutions need to be implemented within the short term to really address that potential drop off, but also thinking really long term in terms of putting in that time so that there is a more permanent solution for addressing churn. Now, it is, and the reason why we developed this prioritization table is because it's unlikely a state will be able to implement or immediately address all of the policies and processes that they are interested in. So we really hope users will utilize this table to identify and prioritize solutions that are currently feasible and sustainable. And once users have identified the policy and practice solutions to move forward with, gaining the appropriate approvals from leadership, we have the final table within this tool, which is the action plan. Now, the action plan is designed to help Medicaid agencies move from a place of information gathering, planning, and prioritizing to actual implementation. And the resources is intended for users to document key information about the activities and subtasks needed to implement a specific policy or process solution that was identified in the previous prioritization table. We designed this tool to have users be able to clearly articulate the activities that need to take place, the staff who would lead that work, the key partners and stakeholders, both internal and external, who need to be involved in order for that activity or subtask to take place, as well as any resource or technical assistance needs. And finally, to evaluate each step along the way. We really hope that this action plan would be a tool to keep to keep states accountable and keep states on a nice deadline for moving the work forward and to making sure that the goals that were initially articulated and the policy and process changes that were laid out in this document are achieved. Now, before I pass it back to Erin, who will moderate the Q&A section, I do want to flag that we view the entire toolkit as a dynamic resource, and we really do intend for states to revisit, modify, and update the individual tools as needed as they are working through this toolkit to ensure that their work is successful. And as next steps, thanks, Erin. As next steps, BDT, we stand ready to assist states that are interested in using this toolkit. We would want to offer to any states that are on this call or watching this recording back that if states are interested in having technical assistance in the implementation of this toolkit, that you can contact BDT at partnerships@bdtrust.org. And finally, we really do strive to make this a dynamic resource. And we know that we will learn a lot from states and from others who are using this toolkit and would greatly value any feedback. And if there are ways in which we can improve the products, the tools within this toolkit to make this a more useful resource, we want to invite everyone that's on this call and everyone that will be using the toolkit to provide us with feedback so we can continue to improve upon, add to, and make this the most beneficial resource for states. And of course, if you have any questions, let us know. So Erin, I'm going to pass it back to you for our Q&A segment.
Happy to take it back. Yeah, we can sit here in silence for just a few minutes and you guys can take a moment to think, write things in the chat. We're here to answer your questions. And we're also here later when you start to use this and think about it and it gets complicated or you're not sure what you need to do. We're here to answer questions then too. It doesn't have to be now. That's a great question, Ali. So Jamila, you or I could take this. You may be better positioned for me, but the question is, do we hope states will start using the toolkit before the end of the PHE? I think the answer is absolutely yes. Jamila, if you want to expand on that, you're certainly welcome to do that.
Yes, Ali, and thank you for that question. We certainly do hope that states will start digging into the toolkit before the end of the PHE. As you saw from some of the earliest slides, some of those first tools will require a lot of effort in pulling together the right internal and external stakeholders that will be needed to ensure that this is successful. And the quicker states are able to move this toolkit into an implementation phase, the more time that it affords them so that they can be ready to act and implement once the PHE ends.
Jamila, go ahead. I know you got this one.
That is a great question. And that is actually one of the things that we talk about in sort of the first step of the toolkit, the readiness assessment. Is there going to be leadership support and leadership buy-in to do this work? And we know from the literature that's already out there, from our information, our conversation with key informant interviews, that for each state, the selling point is going to be something a little bit different. But at the core, we know that all states and all agencies want to ensure that their citizens are happy, are healthy, are able to reach that level of economic and physical and personal success. And the data clearly shows that folks that do experience churn are more likely to have higher poor health outcomes, are more likely to have higher healthcare costs, which has a direct impact on the state in terms of costs, and also has higher health administrative costs, which again is associated with folks that need to be processed and reprocessed I know that the state of, in doing our research, we did see that the states of California actually did some extensive research in terms of understanding the impact of Medicaid churn on particularly children, which we know is a particularly stable population, and understanding the millions of dollars that is lost in simply reprocessing members. And we also know from sort of recent conversations with states that there are a number of challenges now when it comes to capacity. And as the public health emergency ends, we know that states are particularly mindful of capacity constraints and capacity needs, and the challenge that will possess when they need to re-enroll folks. So thinking about things that can be put in place to, one, help automate and ensure that folks going through the ex parte process, but also ensuring that folks have enough time and enough notice that they can send in more complete renewal forms so that they don't have to do all of those reprocessing.
One of the questions too that came in the Q&A is, what are examples of ways that BDT has provided technical assistance to states before, and what outcomes are there to speak of? I think the latest numbers from, I'd have to look exactly, 2021 are that we have provided policy and practice technical assistance that streamlined access to benefits for, I believe, upwards of 2.5 million people through various policy and practice changes, including some work that we did with a number of states in texting outreach for people who are on SNAP or Medicaid or even foster care assistance to get them enrolled in WIC. We have provided policy and practice TA to a number of states around ESAP waivers and various things over the course of the last couple of years. I probably not exactly the time and place to get into it, but I know our website has a robust collection of the policy and technical assistance offerings and briefs and memos and toolkits and things that we have done in the past, but really have had an impact, and we're continuing to gear up our policy work here at BDT. Any other questions? Another question is how to connect with us. Hang on just a second. Let me screen share again so you have that email address. Partnerships@bdtrust.org is the best way. You can also individually find me and Jamila on the staff bios page of the BDT website if you want to get to us directly, but we'll get what you send to that inbox there. Also, if you guys, we would love if you're not already getting our newsletter. I know many of you are following us on the Twitters or the Facebook or LinkedIn for sure. You can scan the code with your phone and subscribe to our newsletter. Jamila, a question from Dottie. What do you see as the most promising practices, policies states can adopt to reduce Medicaid churn? I know you're ready for that one.
Yes, and I know this is not going to come as any surprise to folks on the phone, because probably heard it or read it somewhere, but 12-month continuous eligibility has been shown, and there's a lot of research out there that shows that 12-month continuous eligibility is the most effective way of reducing or eliminating Medicaid churn. And that is an option that exists that states can take up. States can adopt 12-month continuous eligibility for children through a state plan amendment, as well as they can adopt it for adults as well through a waiver. And I know that we have all probably seen that states now also have the option to adopt 12-month continuous postpartum coverage. And there are a number of states that have taken up that opportunity, which I think is great, especially given some of the very troubling information and data that exists about the disparities when it comes to maternal mortality and Black women particularly. And what I think is really interesting about the option for 12-month continuous eligibility, and this is something that I know has a lot of people wary because of the cost that is associated with that, is that because of the COVID-19 pandemic, every single state has essentially gone through this natural experiment in 12-month continuous eligibility. And I think that this is a really great opportunity for states to really sit and consider and think about the impact that this continuous coverage requirement has had over the last 12 months. I know that, yes, we certainly have to take into account that there was that FMAP increase that will play a role, and there were definitely some changes in the way in which people utilize the healthcare system because of COVID. But I think that, and we know that there have been guidance coming out from CMS for states to really consider populations that are more stable, that could benefit from options like 12-month continuous eligibility. And to kind of get off of the 12-month continuous eligibility train for a little bit, there are other options for states to consider, like extending certification periods for non-MAGI enrollees, extending the certification window just generally. Expanding Medicaid remains an option for states that have not yet expanded, that can help create a higher eligibility threshold and prevent the folks with temporary income fluctuations from experiencing coverage gaps. And of course, expanding the use of ex parte renewals. We know that is a requirement for the MAGI population. And by expanding ex parte renewals, it creates efficiencies all around. By automating that process, it not only benefits the Medicaid agency, but it also takes the burden off of beneficiaries to re-enroll. And Trish, thank you for pointing that out, Trisha. That was a huge point that came up in our research in our interviews as well. Periodic income checks there was a huge rise in that in the last administration as a way of promoting program integrity. But we also know that there was a lot of information that came out of that when a state implemented more periodic data checks, we saw a lot more folks lose coverage. So really, I think there is the option for states to really consider, the impact of implementing periodic eligibility and whether that actually results in any savings because of the now price of reprocessing folks more frequently. And I did want to flag that on the webpage, we actually do have a FAQ document that states can utilize to that does provide a little bit more information about what Medicaid churn, what the impacts are, and what are the potential policy and practice solutions that states can leverage. And I know Erin alluded to this as well, but a simple process solution is using text messaging. That is something that BDT does employ in our work currently. We know that a number of folks lose coverage because of those procedural barriers, such as not receiving mail. And given that, in a pandemic that has lasted this long, we can expect folks having moved within the last year and may not receive their mail. So, thinking about texting as an option to engage folks and as an option for outreach is another way in which states can really consider that, consider process solutions to reducing churn.
Just making sure we don't have any additional questions. Give folks just one more minute. Thank you for that comprehensive answer, Jamila. I do want to say, while we're giving everybody just one last minute to get, or two, or whatever you need to take, to get in your questions, I did mean to say this at the beginning, and I would be remiss if I didn't say this. Many thanks to all of the partners and states and organizations who were part of the sort of discovery phase of this work, who took interviews, answered calls, answered questions, but helped further our understanding and put together the package that is this toolkit. So lots of thanks to those folks and the states. So if there are no last questions, this is how you can get to us. Get our newsletter, check out the toolkit. I think, Jamila, correct me if I'm wrong, there's been 115 plus downloads in the first week or so of the toolkit being up. Continue to do that. And please don't be afraid to reach out as you're working through it, or if you're a partner, if you're working through it with a state or talking to a state, we're here to support. So we really appreciate everybody being a part of the conversation today. And yeah. Have a great rest of your Thursday, everyone.